patients that have a diagnosis of a tic disorder require what we call psychoeducation, which is information about the disorder in order to provide support. Not all people who have been diagnosed with Tourette syndrome will decide that they want to be treated medically. Tics wax and wane. They fluctuate in frequency and severity over time. Tics in and of themselves are not harmful. So in some people who do not feel that they're experiencing any impairment or disability related to their tics, they don't require any active intervention other than that, that reassurance that, these tics are not harmful. If they're not bothering you, this is not something we need to treat aggressively. We can watch and wait, regular check-ins with your physician. If anything is changing, if the tics are becoming painful, emotionally distressing, or are preventing you from engaging in activities you enjoy, then we can talk about the different treatments that are available. In some people, even if the tics are not causing impairment, they may be motivated to attempt the comprehensive behavioral intervention for tics, which is a behavioral therapy, which has been shown to be very effective for the treatment of tics. The reason why this would be recommended in patients who are not experiencing functional impairment is that there are no harms related to this treatment. So in terms of the standard treatment for tics in Tourette syndrome, which are causing functional impairment, we do have both behavioral therapies and pharmacotherapies, which are strongly supported by evidence to use. So the comprehensive behavioral intervention for tics is a behavioral therapy that has in which we have high confidence in the evidence to support its use. This is the recommended first-line intervention for people over the age of 9 that have tics. There is data to support its use both in children and adults. There is some data for exposure and response prevention, which is another type of behavioral therapy, but the evidence is not as strong. We've recommended this type of behavioral therapy when the comprehensive behavioral intervention for tics is not available. With respect to pharmacotherapy, we do have data to support the use of the alpha-adrenergic agonists. This is clonidine and guanfacine for the treatment of tics, as well as a number of anti-psychotic medications, including aripiprazole, risperidone, ziprasidone, haloperidol, pimozide, and tiopride. Now, these antipsychotic medications, while there's sort of different levels of evidence to support their use, we recommend that people really make the choice based on their patient and the adverse effect profile of the medication. All antipsychotic drugs are associated with drug-induced movement disorders, metabolic effects, and hormonal effects, though the relative propensity for these adverse effects varies between agent. So deciding which drug to use really should be based on a collaborative decision between patient and caregiver. There is evidence to support the use of topiramate, an anti-epileptic medication for the treatment of tics, as well as botulinum toxin injections into the face, neck, and shoulder region in patients with motor tics. There is also some evidence for the treatment of vocal tics, severe vocal tics, using botulinum toxin injections. There's preliminary evidence for the use of deep brain stimulation, though this is not something that is extensively used in Tourette syndrome, and experience is really quite limited to a few centers. Finally, there is some evidence on the use of cannabis, though the data that has been published is limited to THC.